When we left off on Monday, I was telling you about the specialized and the contractile cells of the body, specifically of the heart, I should say. And the specialized cells, as you heard me say on Monday, are able to reach threshold on their own. They can generate their own action potential. The way they do this is by accumulating positive charges. That is how they go from about minus 70 millivolts up to about minus 55, which is our number for threshold. So they accumulate positive charges. The way they do this is they are less leaky to potassium. So if potassium is trapped in the cell, that would be a gain of positive charges. And they are more leaky to both sodium and calcium. So between those three ions, it is very easy for these specialized cells to trap positive charges and reach threshold. How are they able to do this on their own without a nerve innervating them? It's gene expression. They express different types of potassium leak channels and sodium leak channels and calcium leak channels. The specialized cells have very distinct names when we are finding them in the heart. All of the bullets that are shown here next to names are showing you the names of the specialized cells. The SA node, sinoatrial node, the internodal pathway, then the AV node, which stands for atrioventricular node. Then we have the atrioventricular bundle, also known as the bundle of His. Then we have the bundle branches. There's a right bundle branch and a left bundle branch. And lastly, we have these specialized cells that go around the lateral walls of the ventricles, and those are called Purkinje fibers. So everything you see with a bullet here is a specialized cell. Now the SA node and AV node are both found in the right atrium. The SA node is found in the ceiling of the right atrium, and the AV node is found in the floor of the right atrium. The internodal bundles connect the SA node to the AV node, but they also cross the septum that's found in between the atria. A septum means wall. Well, how do we get our four chambers? Clearly, there has to be walls or valves that make up some sort of barrier or border. So in between the two atria, we have an interatrial septum. And the internodal bundles not only go from SA node down to AV node, but they also travel from the right atrium to the left. The atrioventricular bundle, also known as the bundle of His, is a small part of the specialized cell system. And it worms its way through a different wall. This septum is the septum that separates the atria from the ventricles. This is called the Atrial Ventricular Septum. Obviously, the valves called the AV valves are basically, when they close, they're plugging holes that go through the AV septum. The bundle of His, or atrioventricular bundle, has grown through this wall that separates the atria and ventricles. That AV bundle, or bundle of His, is very important. The cells are small. They don't have a lot of intercalated discs. What does that mean to you? It means that the action potential does not spread straight from the atrium down to the ventricles. There's kind of a tunnel point, a funnel, I should say, where everything merges at the AV bundle. Think of it like a traffic jam. So this electrical current comes to the bundle of His, AV bundle, and it gets slowed. Small fibers, very few intercalated discs to connect one cell to the next. And this means there is a delay in the conduction of the electric signal, the action potential, that goes from the atrium down to the ventricles. That delay is important. It ensures that the atria get their electrical event, then mechanical, before the ventricles get their electrical and mechanical. It ensures we have atria, then ventricles contracting, instead of at the same time. And on Monday, we appreciated the idea of if Jessica and I were both pressing on a door with equal and opposite strength, no one would get through that door. It would not be able to open. Blood flows to, through, and out of your heart through the opening and closing of these valves. They ensure one-way directional movement of blood. If we did not have atrial, then ventricular syncytium, if all four chambers contracted and relaxed at the same time, blood would not be able to move from one chamber to the next and then out of the heart. These valves open and close due to pressure changes, not from physical contraction of the heart working directly on those valves. They open and close because of blood pressure differences on either side of the valve. So that AV nodal delay is really important. It ensures atrial, then ventricular syncytium. Let me just pause. And then the rest of the specialized cells, after the bundle of His, the right and left bundle branches travel through the interventricular septum. That's the wall between the right and left ventricle. And the Purkinje fibers are found on the lateral walls of the ventricles. Are there any questions about the specialized cells right now?
I do have a quick question. The Purkinje fibers, you said they travel along the lateral walls of what?
The ventricles.
Okay, thank you.
So if you look down here, Jessica, they are right along here.
I don't, hold on. I don't see what you're pointing. Oh, I see. Okay.
The blue that I just covered.
Yes.
Okay.
Sorry, my Zoom thing had covered it up, so I couldn't see. Thank you.
You're welcome. Now, in physiology, you learn about these specialized cells, and you also learn about a machine called an electrocardiograph. The electrocardiograph is the machine. The electrocardiogram is the picture that you're seeing on this screen. In most schools, they teach you the following in physiology. And what I'm about to teach you in anatomy that I do expect you to know, this is what they teach in physiology. P wave. What does the P wave represent? It represents atrial depolarization. So I'm going to just put P, atrial depol. I'm just going to abbreviate it. The QRS that you are seeing is referred to as the QRS complex. My computer doesn't like it when I am doing two different kinds of recording. The QRS complex represents ventricular depolarization, and the T wave represents ventricular repolarization. And we know what depolarization and repolarization means. We also know that these are electrical events and mechanical events occur as a result. If the atria depolarize, what will they do next? They're going to contract. If the ventricles depolarize, what will they do next? They're going to contract. And if the ventricles repolarize, what will they do next? They will relax. We forget that contraction is a mechanical event that follows an electrical event all too often. We also forget, even more it seems, that relaxation is a mechanical event that follows an electrical event called repolarization. Students that are paying attention right about now say, Kara, where is atrial repolarization? That electrical event is occurring pretty much at the same time as the electrical event of the QRS complex. And because the QRS complex is a much larger electrical event, it hides, it masks the electrical event of the atria when they repolarize. So they're happening virtually simultaneously, and the machine registers the larger event. Because the ventricles are greater in muscle mass, they generate a greater electrical current. And therefore, the machine picks up on that event more so than the atrial repolarization. Now let's do it again, but add another layer to our learning. If the atria depolarize, what will they do?
Contract.
Thank you. And when the atria contracts, what will happen to the blood inside? Blood will be pushed through the AV valves down to the ventricles. That's what's going to happen as a result. What will happen when the ventricles start to depolarize? They will start to contract. What will happen as a result? As the ventricles press on the blood inside, it will raise the blood up in that chamber. As the blood goes up, it pushes on the underside of the AV valves, closing them. This prohibits blood from regurgitating backwards from the ventricles back to the atria. That's not where we want it to go. As the ventricles continue to contract, they generate enough pressure to open a different door. Isn't this neat? The ventricles are generating pressure to close one door, the AV valves, and open different doors, the semilunar valves. And when the ventricles generate enough pressure to open the semilunar valves, what will happen? The right ventricle will eject blood out of the heart into the pulmonary artery, sending blood to the pulmonary circuit for gas exchange. On the left side of the heart, the left ventricle ejects blood into the aorta, sending oxygen-rich blood to the systemic circulation of the body. When the ventricles repolarize, when we see the T wave, the ventricles are repolarizing and they start to relax. When they are completely relaxed, we see this part on our EKG, this flat line, and it's called the TP segment. It's named that because it's the flat line between the T wave and the next P wave, representing the next cardiac cycle. The next beat will occur as a result. Students look at this flat line and they think, well, electrically, nothing is happening. True, electrically, nothing is happening. That's why the pen is flatlined. But something very important is going on during this resting time. That flat line, that TP segment, represents diastasis, a word I told you about on Monday. Diastasis is when all four chambers are relaxed. What is happening at that time? The heart is starting to fill with blood, priming itself like a pump should, full of blood so that it's ready to eject the next stroke volume, which is about 70 milliliters. But something else important is happening to the heart that I told you about on Monday, and I made a joke about it. During this time, this is the only time blood is able to get into the right and left coronary artery. This is the only time blood is flowing to the tissue of the heart for the purpose of delivering oxygen and nutrients. And this TP segment is abbreviated the most, disproportionately abbreviated the most out of all the other events you're seeing here on the cardiac cycle. And the joke I made on Monday was arguably this is a reason why we shouldn't exercise. But then I explained the benefits of exercise when we are finished with exercising. Are there any questions about this? Okay, well, before I do it again, oops, I'm moving my picture and I don't want to move that picture. I want to move me. There we go. Before I move on to the next slide, I want you to see up here, going from one R to the next R represents 800 milliseconds. That's roughly the time required for one cardiac cycle, meaning going from beat to beat. We're going to go through the events of the cardiac cycle step by step. It is a circular cycle, right? So where I begin in the cycle is arbitrary. As long as I finish where I begin, we'll go through one complete cardiac cycle. I like to begin at diastasis, this TP segment, where nothing electrically is happening. So I'm going to do this cardiac cycle a few times. And I'm going to do this once on this slide. Then I'm going to tell you on the next slide how your heart rate can be changed by nerves that innervate your heart. And then I'm going to go through the cardiac cycle again a couple more times on later slides. Our story begins at the TP segment. This is diastasis. No specialized cells are firing. No action potential is happening. Everything is relaxed. Blood returns from the pulmonary circuit into the left atrium. Blood returns from the systemic circuit into the right atrium. So blood is returning to the atria, but from different places. That blood pools on top of the AV valves, making them open, swinging open. That blood immediately pours into the ventricles. Again, the entire heart is at rest. Blood continues to pour into the right and left ventricle. Just like you pouring a drink into a glass, this makes a sound because the blood is sloshing around in the ventricles. This is actually making a heart sound that most textbooks don't talk about. It is heart sound. It's heart sound 3. I had to go through them all and get them straight in my head. So heart sound 3. In your textbook, it talks about only heart sound 1 and 2. Where is this 3 coming from? Well, there's not just a 3, there's a heart sound 4. In order to hear heart sounds 3 and 4, we need special machinery. We don't need special machinery to hear heart sounds 1 and 2. I'm sure many of you have had your head on someone's chest and you can hear their heart beating. You were hearing heart sounds 1 and 2. Not even a typical stethoscope helps us hear heart sound 3 nor 4. A very sensitive device needs to be used. So as the blood is pouring from the atria into the ventricles, the blood is sloshing around, and this is heart sound 3. This is called passive filling of the ventricles. Nothing is contracting. Nothing is pushing the blood in due to muscle contraction. Then we do see the P wave. We see that on our patient's ECG. What does that mean? The atria are depolarizing. Well, what has happened? The SA node has fired. And that action potential is spreading through the atria. They now will contract. And they will squeeze a little bit more blood down into the ventricles. And now the ventricles will be maximally filled. They will have about 120 milliliters right now inside them. So this is no longer passive filling, and when the atrias are contracting and squishing this last little bit of blood into the ventricles, it sloshes everything around again, and we hear heart sound 4. Now that electrical signal gets through the bundle of His, goes down through the IV septum, through the right and left bundle branches. The ventricles are starting to contract. The apex is pulled up superiorly because the IV septum starts to contract. The electrical current spreads along the lateral walls of the ventricles through the Purkinje fibers. And as the apex of the heart is being pulled up, the blood is raised superiorly and the blood pushes the AV valves closed. This is a special moment in the cardiac cycle. This is known as isovolumic contraction. What does it mean? The ventricles are contracting. Isovolumic means no blood is coming in and no blood is exiting. Iso means same volume contraction. All 4 valves are closed. Nothing can come in, nothing can leave the ventricles. Soon the ventricles generate, as they're generating this pressure, the blood inside with nowhere to go is sloshing around. And that is what is creating heart sound 1, your lub sound. So lub sound comes from the ventricles contracting, closing the AV valves, and the blood is sloshing around, much like I'm sloshing around my tea inside my container. I can hear it. That's the lub sound. The ventricles then generate so much pressure that they open the semilunar valves, which are found in the ceiling of the ventricles. And now we get ejection. How much blood is ejected of the 120 milliliters we have in there? 70. Yeah, we don't get it all out. Then the T wave appears, and we know that means the ventricles will repolarize, which means they will relax. And as they relax, that blood that was ejected up into the pulmonary trunk on the right side and the aorta on the left side starts to momentarily slip backwards, regurgitate. But then that blood fills those cup-like valves of the semilunar valves. And now those cups are filled and they block that opening. We don't get regurgitation. And that blood that was sliding backwards now hits a closed valve, and that blood is sloshing around on top of those semilunar valves, creating another sound, heart sound 2. Your dub sound. Let's talk about heart sounds a little bit more. It annoys me to no end. When I get to physiology, anatomy is a prereq for physiology, and I ask my students, tell me what makes heart sound 1 and 2. What makes the lub-dub sound? My anatomy students know better, and they just do this. They are just quiet because they know what's about to happen. Someone else in the class is going to raise their hand, and I'll say, yes, please tell me. And they will say, heart sound 1 is from the AV valves closing, and heart sound 2 is from the semilunar valves closing. And I say, nope, absolutely not. Then they find their online textbook on their phone, raise their hand again, and I wait for it. Says right here in the book, that's what heart sound 1 and heart sound 2, that's what causes them. I said, no. Closing the valves, are my hands making a sound to you right now? They're not. It's not like they're slapping. The valves are soft structures. They don't make a sound when they close. That's not the answer. Turbulent flow makes a sound, and I'll prove it to you. If you're lost in a forest and you're in need of water, where would you rather be lost in the nearby vicinity? To a river or a stream or a lake? And why?
River or stream, because the water is flowing and there's less bacteria. There's nothing stagnant.
Okay.
The water.
So we'll address the bacteria at a later time.
Okay.
You can hear the stream and river.
Correct. Absolutely. You can hear it. Why? There are currents in the stream, in the river. Okay, well, water flowing is also happening in the lake. It absolutely is. There are lake currents. But you don't hear that flow of water because it's streamlined. It's laminar flow. Turbulent flow makes sound. Here is laminar flow. The tea was flowing. The only sound made is when I swallow. But if I were to open my container and pour my tea out on the table all over in front of me, it would make a sound. Splashing sound, turbulent sound. Rivers only make sounds when the flow isn't laminar, when it's hitting some sort of obstruction and swirling to some extent, like in the rapids. Lakes also have flow of water. Something feeds the lake. But if it's laminar flow, it doesn't make a sound. When students say, well, the reason why you're getting that turbulent sound is because those valves closed. And I say, oh, so the heart doesn't make any sounds when the valves are open? No, they say. And I say, really? I beg to differ, because there's heart sound 3 and 4. And heart sound 3 and 4 happened when the AV valves were open. Again, because of turbulent flow. And then I really blow their mind and I say, how do we take someone's blood pressure? And they start saying, well, we use a stethoscope and a sphygmomanometer blood pressure cuff. And I said, yeah, and what are you listening for? Sounds. Where are they coming from? It's not coming from valves opening or closing. It's coming from the blood in someone's brachial artery, going from no flow, no sound, to all of a sudden there's flow allowed because the cuff releases pressure and the blood is jetted through the opening of the brachial artery and it's just spurting and it's turbulent flow. And we hear this kind of thumping sound. We know to look at the dial and we know that's our systolic blood pressure. Then I say to them, when do we look at the dial to take diastolic? And they say, oh, when the sound disappears. Why? Why does it disappear? I don't know. Well, there's still blood flow. There's still blood flowing. So why is it not making sound anymore? Any ideas?
It's not turbulent.
It's laminar. Absolutely. So that was one cardiac cycle. And, well, Derek, I would be careful if I were you. When your teacher eventually teaches you about the heart sounds, if your teacher says heart sounds 1 and 2 happen because the AV valves close and the semilunar valves close respectively, I suggest you bite your tongue and not raise your hand and do not ask your professor to finish his sentence because his answer is incomplete. You probably won't be the favorite student at that point. But that
I already got taught. So.
You already got what?
He already taught that.
Oh, he did? And is that what he said?
The sound of the turbulence created when the heart valves snap shut.
Okay, the snap. He almost had it. Did anyone ask about heart sound 3 and 4?
No, he just briefly went over that, but mainly 1 and 2, like you said.
Well, at least he put in there the turbulent blood. It's the blood that makes the sound when it's turbulent.
I know. I was listening to you. I was like, oh, it's interesting. You backed it up, and it was a good explanation.
Yeah. That's what I do. All right. So that was my first attempt telling you about this amazing cardiac cycle. Now let me tell you how your heart rate can be changed, not just by you exercising. Of course, the heart is innervated. Of course, there are nerves that communicate to it. But your heart doesn't need them. We can do heart transplants. We don't reconnect the nerves. There's no way for us to do that. That's like trying to sew together paintbrush bristles from 2 different paintbrushes. Not going to happen. So your heart has this autorhythmicity. So what in the heck are those nerves doing? They represent 2 very cool divisions of your nervous system. This is called your autonomic nervous system. Your fight or flight, which is your sympathetic nervous system, and your resting calm blue ocean, parasympathetic division. So when your parasympathetic division has more control over your body, when you are in calm blue ocean mode, as I like to say, your heart rate goes down. And the fancy way of saying that clinically, we say you have decreased chronotropy. Chrono means time. Decreased heart rate. Fewer beats per minute. That's the time part. When you are in a fight or flight response, and you all can have a sort of fight or flight response right now without moving. You can think of something terrifying, maybe something that has happened to you in the past, and you feel your heart rate going up and the force of contraction. You feel your pounding heart. And that's your sympathetic division taking more control. Now, when your heart rate goes up, we say this is positive chronotropy. Again, time. But the sympathetic division also makes your ventricles contract with greater force. And that's referred to as inotropy. So when your sympathetic fight or flight response kicks in, your chronotropy goes up, but so does your inotropy, the pounding, fast beating heart that we think of, feel when we're scared. So your parasympathetic division slows your heart rate down. How does it do this? It targets your SA node. It makes that SA node take longer to reach threshold. When your sympathetic division takes control, it makes the SA node reach threshold faster. There's more to that story. There is more to heart physiology, but you are not yet in physiology, and I have to save some cookies for that class. But the heart is oftentimes a chapter where I get a lot of questions where students are like, why does this happen? Why does this happen? So I think it's interesting. And it's good stuff to know when you're learning anatomy. It's nice to be able to put function with form. So what parts of your brain are basically communicating to your heart through these nerves that you're seeing. These, it looks like spaghetti on this picture in front of you. There are different parts in your brain that can give input. They give their opinion, if you want to think of it like that, to your heart rate. One is this tiny little part in your brain called the hypothalamus. Your hypothalamus controls things like rage, sexual desire, feeding behavior, when you get excitable. So no wonder the hypothalamus can influence your heart rate. The amygdala is another part of your brain in close proximity to the hypothalamus. They do kind of communicate to each other. And your amygdala is that part in your brain that nags at you. And when you try and describe this nagging sensation, sometimes you might turn to a friend and you might say, I have the creeps right now. We need to get out of here. Or you might say, I have the heebie-jeebies right now. Something's not right. I'm not feeling comfortable for some reason. It's that little voice in your brain that comes from your amygdala. And it's your fear center. And chances are when you get that voice saying something's not right, you have probably seen something happening in the distance. You weren't consciously aware of it, but in your peripheral vision, you probably saw something. And these other remote parts in your brain were piecing things together, and then your amygdala went, you didn't see that real clearly, but it's probably not a good idea for you to be there right now. Let's go. This is not right. Get out of there. So it's that nagging little warning voice. Your amygdala also stores memories, intense memories that were forged in fear. And sometimes these fearful memories can be make you so fearful that oftentimes as a coping mechanism, we forget about them. But they're still in there somewhere. And that's your amygdala. It's your amygdala that remembers things like when you hear that buzzing sound by your ear and you start going, because you know it's a bee or a wasp. It's your amygdala going, yeah, that sound last time hurt you. So get away from it. That's what your amygdala does. And obviously when you're afraid, your heart rate goes up. There are other parts like your medulla oblongata, part of your brainstem, that also influences on a more moment-to-moment basis. The medulla oblongata is kind of like, that's the main place where your every second, day-to-day heart rate is regulated. Fear, sex, rage, kind of emotions, those different parts of the brain emotionally impact your heart rate. Are there any questions before I go back to the cardiac cycle and do it again? I hope I'm not boring you. Okay, so on this slide and the next, it is showing you one full cardiac cycle. And as you can see in the description of these pictures at the top, this slide says ventricular systole, contraction. And this one down here is showing you ventricular diastole. And students oftentimes say, well, why aren't they pointing out atria? Well, the ventricles get all of the fun and all of the focus because they are, one, bigger. Number two, because they're bigger, they generate more contractile force. And three, they're the chambers that, with that contractile force, are ejecting the blood, the stroke volume, out into the pulmonary trunk from the right side, or the aorta from the left side. So I am going to start here with this picture. This picture showing you ventricular diastole, relaxation. Look at this top picture and look carefully at those red arrows. The heart is in diastasis right now. Everything is relaxed. On the right side of the heart, we see blood returning to the right atrium from the superior vena cava and the inferior vena cava. And there's missing red arrow. There's also blood coming from the coronary sinus, from the back of the heart in. On the left side, we see blood coming back through the paired pulmonary veins, bringing oxygen-rich blood into the left atrium. You're seeing in this picture that both the right and left AV valves are open. Why? Because the blood coming back into the atria opens that trap door. Those leaflets just open like a trap door because of the pressure from the blood. Nothing is contracting to make those valves open. The blood keeps pouring into the ventricles, and this is where we get heart sound 3, passive filling. This picture down here, you can see what it looks like when the AV valves are open. And we see at this moment that those 3 cusps for the semilunar valves for each one, those are closed. So at this point in time, the blood is pooling on top of those closed semilunar valves. And for the aortic semilunar valve, we have the opening of the coronary arteries. And at this moment in time, blood is traveling to the right and left coronary artery, to the coronary circulation, and delivering well-deserved oxygen and nutrients to the heart tissue. This picture up here is showing you what those, just a transverse section, if you will, looking at what those semilunar cusps look like when they're closed. And these leaflets on this side, what they look like in the AV valves when they're open. At this moment on our EKG, we would see the P wave appear, representing atrial depolarization. What will the atria do? Contract. What will happen? Just a little bit more blood. Just a little bit more blood is pushed into the ventricles. I like to think of it as topping off your gas tank. You know, when you go and fill your gas tank up, you might pull up on the little lever and use the little holder, and your hand's free. And your tank is filling passively. You don't need to hold that lever. You can be hands-free. But when you hear that little pump shut off and the lever holder snaps away, you know your tank is full. Do you stop there? Oh, no, you don't, because you want to try and squeeze out maybe another gallon or so. So you pull up on that little lever and you're topping off your tank. That's what I think of when the atria finally do contract. Just a little bit of squirt, just a little bit of extra blood into those ventricles, just a little top off. But most of it happened hands-free, passively. We hear heart sound 4 at this time. From that extra little squirt of blood, turbulent blood, heart sound 4. Now what do we see in our EKG? We see the QRS complex. What will happen? The ventricles will start to contract. The IV septum contracts first. Why? It got its action potential first from the right and left bundle branches. What happens is the apex of the heart is now pulled up superiorly. As the blood resting in the ventricles, as the IV septum and the apex pull up, the blood is also pushed up superiorly. This closes the AV valves. The semilunar valves are still closed. This is called isovolumic contraction. All 4 valves are closed. The ventricles now have the action potential reaching the Purkinje fibers on the lateral walls of the ventricles, and those ventricle walls start to squeeze in. So the heart, the apex, the IV septum pulls the apex up, and then the lateral walls squeeze. Lateral walls relax first, we'll see, and the apex drops. Up, squeeze, relax, drop. That's how the ventricles contract and then relax. So when the lateral walls contract, now there's enough pressure on the blood to open the semilunar valves. And that's what we're seeing in this slide. The semilunar valves are now open. We see that down here from a superior view. And those AV valves, the leaflets, are still closed. Notice the lateral walls in this top picture. Notice how they're squeezed in, much like how my hands squeezed in just now when I showed you. The blood is ejected. What will happen next? Electrically, we see the T wave appear on our EKG. What does that mean? The electrical event of repolarization happens for the ventricles. What will they do mechanically? They will relax. The lateral walls relax first. As that happens, the blood that was ejected momentarily regurgitates backwards, but fills those cusp-like valves of the semilunar valves. See the blood on top? And then the IV septum relaxes, and the bottom, the apex, droops back. As this is happening, as the lateral walls relax and the blood momentarily regurgitates and those semilunar valves shut and the blood is turbulent on top, we hear that second heart sound. Blood is now perfusing, flowing to the cardiac tissue through the coronary arteries. All 4 valves are again closed. I didn't mention this before, but this is now called isovolumic relaxation. And when the IV septum relaxes, and now all 4 chambers are relaxed, we are back in diastasis. We are in that moment of time where we're seeing the TP segment again. Any questions? All right, well then, here is another picture showing you the cardiac cycle. And I like this picture because it shows you not just atrial systole and atrial diastole, but also ventricular systole and ventricular diastole. It's showing you also the time when all 4 chambers can be relaxed. And it's also showing you times when the valves are open or closed. When you listen to this video again, when you're working on your homework packet, when you're trying to piece together the cardiac cycle, I find this picture to be very helpful. It has a nice little chart in the middle, and it has pictures of the heart, and you can see when chambers are contracting or relaxing. I just think it's very nice to follow along. I started my story at diastasis. I started down here. When all 4 chambers are relaxed, blood is returning to the atria and the AV valves are open. So I go from this picture, all the AV valves are now open, and we are starting to get filling, passive filling. And then we'll see atrial contraction. Here is another very good diagram, flow chart, whatever you want to call it, showing you the flow of blood going from the systemic circulation, returning to the right atrium from the superior and inferior vena cava, and dang it, blood also returns to the right atrium from the coronary sinus. I get irked that is omitted too often.
It's in the boxes on the bottom.
Yeah, I know, but why can't they show it here in the picture? Because I'll tell you why. Students pay attention to pictures more than they do words in a table. So why could they not have filled that in up there? That's all right, we did. The right atrium, blood flows through the AV valve, the right atrioventricular valve, also known as the tricuspid. To the right ventricle, and blood ejects into the pulmonary circuit through the pulmonary semilunar valve. It goes to the pulmonary circuit for gas exchange. CO2 is dropped off, leaves the blood, goes into the lungs, and oxygen moves from the lungs into the blood. Blood returns to the left atrium through the paired pulmonary veins. So that means there's 4 total. There's 2 right pulmonary veins and 2 left pulmonary veins. Blood goes through the left AV valve from the left atrium into the left ventricle, and that valve is also known as the bicuspid or mitral valve. And once the blood is ejected from the left ventricle, it goes through the aortic semilunar valve into the aorta, into the systemic circulation, where now oxygen leaves the blood and enters tissues for cellular respiration, and CO2 that is made from the cells in the tissues during cellular respiration enters the blood to come back to the heart, and the cycle repeats. This is a flow chart you see in your homework packet, and you see it in more than one form. Maybe you've seen it already in your homework packet. If you're also looking at your homework packet critically, you're seeing that there are quite a few flow charts. I want you to know what's the order. Go from here to here to here to here to here. You don't have essays on this exam, but you have flow charts, and that's why they're in your homework packet. I've already covered your lub-dub sounds. Are there any questions about the heart sounds?
Yeah, I have a question. Okay. Can you repeat what makes heart sound number 1 and 2 again?
Heart sound 1 happens when the ventricles begin contracting, when the IV septum pulls up the apex of the heart, the blood inside pushes on the underside of the AV valve and closes them. There is not enough pressure at this moment to open the semilunar valves. yet the heart is contracting, the ventricles are contracting, and it's like me shaking a water bottle. You all can shake a water bottle in front of you if you have one on your desk. That water isn't necessarily going anywhere. I'm not pouring it. I'm not adding to it, but it's turbulent inside. So heart sound 1 happens when the ventricles are contracting. All 4 valves are closed. This is when we hear heart sound 1 during isovolumic contraction. It's from turbulent blood just basically being shook around inside the ventricles with nowhere to go. Heart sound 2 happens during isovolumic relaxation, when again all 4 valves are closed, but this time the turbulent blood is happening because blood is regurgitating on to the closed semilunar valves, and the blood is just sloshing around on top of those valves. Is that better, Keanu?
Yeah. It's a lot better. Yeah.
Okay. So oftentimes also students ask me, why is your doctor moving the stethoscope when they are listening to your heart? And they move it to different places to hear these 4 valves. Now, the 4 valves are very close to each other anatomically. But when your doctor puts the stethoscope between your 2nd and 3rd costal cartilage on the right side, they are listening to one of your basically, well, here in blue, you're seeing this is where the valves are located. So this one up here on the right side, that's where they're putting it to hear your aortic semilunar valve. Okay? And then when they put the stethoscope just to the right of your xiphoid process, that's when they're listening to your right AV valve. Remember, the semilunar valves are way up in the ceiling. They're higher, they're more superior than the AV valves because they're way up inside the ceiling. When your doctor puts the stethoscope just to the left of your sternum, of the body of the sternum, between the 2nd and 3rd rib, that's when they're listening to the pulmonary semilunar valve. And I know that seems weird, because you're thinking, well, the pulmonary semilunar valve is off the right side of the heart. You're right. But those blood vessels developed in a twisting way. So right here represents the aorta. And over here, it's representing, my finger is representing the pulmonary trunk. And so even though the aorta is coming off the left side of the heart, the blood vessel itself is, it's more on the right side, the actual blood vessel. Again, they grew in a twisted fashion. They didn't grow like this. They grew like that. And then when your doctor puts the stethoscope between the 1, 2, 3, 4, 5th and 6th costal cartilage on your left side, they're listening to your left AV valve. So that's why they move it in those 4 different places. Now on to fetal circulation. This is also in your homework packet. When we're talking about a fetus, we are talking about an unborn child, and that's older, more mature than an embryo. So we're usually talking around the 3rd month of gestation onward to birth. There is no reason for blood to go to the pulmonary circuit in a fetus, in an unborn child. Why? They are submerged in fluid. They are not breathing air. Their lungs are actually collapsed. Gas exchange happens through a different organ called the placenta. In the placenta, we have fetal blood flow coming in close proximity to maternal blood flow, which is found in the uterus. So the blood vessels don't grow together, they grow in close proximity. And the fetal blood flow will go in one direction and maternal blood flow will go in the other. And oxygen will go from the mother's blood, move into the fetus's blood. That's how this gas exchange occurs. So there's no reason for blood to go to the lungs. All right, well then let's not send it to the pulmonary circuit. There's no reason to go there. Additionally, the liver is pretty immature. And once you're born, the blood from your abdominal cavity goes to the liver for cleansing, detoxification, before it goes back to the heart. You don't want to distribute nastiness to the whole body, so clean it before that blood goes back to the heart, because you eat nasty things. So blood from the abdominal cavity represents a lot of blood absorbing nutrients and other nasty things potentially from your diet. So it's supposed to be cleansed. Well, the fetus is not eating. The fetus is getting nutrients from mama, and those nutrients are already cleansed. There's nothing coming from the fetus's gut, so there's no reason for abdominal blood to go to the liver for cleansing, because quite frankly, the liver in the fetus is too busy doing other things at this point in development. It's not ready to clean yet. You can think of it a lot like, who asks a 3-year-old to vacuum and dust their room? You don't ask a 3-year-old to do that, not on a regular basis. And if you did, just to keep them occupied, you better not expect it to be done well. They probably could hardly move the vacuum cleaner, for crying out loud. So that's like the liver. In the fetus, it's busy making red blood cells. In the fetus, it's busy making a very important plasma protein called albumin. And the liver will continue to make albumin through your life. So the liver is just developing, and it's doing other important things. It doesn't need to be told to clean the blood at this point. So what you should hear me say is, there's no reason to send the blood to the liver for the sake of cleansing, and there's no reason to send blood to the pulmonary circuit for the sake of gas exchange. All right, then we need to redirect the blood around these structures. We need to avoid them. So the bypass, the blood vessel that bypasses the liver in the fetus is called the Ductus Venosus. So on the left side in the chart down at the bottom, you're seeing the fetal structure. And then once the baby is born, these fetal structures are not needed. We don't want to shunt things anymore. We need to use the lungs. We need to use the liver. So on the right side of this chart, you're seeing what the fetal structures turn into. They're going to turn into things like connective tissue, ligaments. So the ductus venosus shunts blood away from the liver so it doesn't get cleansed. There's no need for it, not in the fetus. Then the blood enters the right atrium, and this is oxygen-rich blood. Isn't that weird? Once the baby's born, the right side of the heart has oxygen poor blood, but in fetal circulation, the chambers are reversed in that regard. So oxygen, somewhat oxygen-rich blood is coming up into the right atrium. It's being met with oxygen-poor blood from the superior and inferior vena cava and coronary sinus. So it gets mixed. It's somewhat oxygenated. That's why in this picture it shows the right and left atrium and ventricle. It's showing the right atrium and right ventricle as being purplish, trying to show you somewhat oxygenated. Well, when the blood returns to the right atrium, if it goes to the right ventricle, it's on its way to the pulmonary circuit. We don't want that. So before you were born, there was a hole in between your atria, a hole in your interatrial septum. There was a hole in the wall. And that was called the foramen ovale. And blood, most of the blood flowed straight from your right atrium to your left atrium. Some blood did get into the right ventricle, and when it contracted, it ejected that blood into the pulmonary trunk, and it's on its way to the lungs, which are collapsed, but there was a vessel connecting the pulmonary trunk to the aorta, and it's labeled here as number 6. A fetal blood vessel called the Ductus Arteriosus. And once you were born, that Ductus Arteriosus collapsed. Why did it collapse? Because you were breathing oxygen, you were breathing on your own, and the higher oxygen content in your blood made that blood vessel vasoconstrict. It is exquisitely sensitive to oxygen levels. And I love this part of anatomy because all of these words are so fun to say, and it's perfect if you're a Harry Potter enthusiast, because then you get to say your ductus venosus turns into your ligamentum arteriosum, venosum, and your ductus arteriosus turns into your ligamentum arteriosum. It's just super fun. Sounds like a nice enchantment or a spell. So your ductus venosus turns into ligamentum venosum. Your ductus arteriosus turns into your ligamentum arteriosum. Your foramen ovale closes, gets sealed shut. We see a little remnant, a little indented region of where that hole used to be, and that's called your fossa ovalis. Other blood vessels disappear. You have blood vessels that went from your pelvic blood vessels out of your body through your umbilical cord to the placenta. Isn't that weird? Think of the placenta like a lung that you had outside of your body where gas exchange happened. So your umbilical arteries carrying oxygen poor blood out of your body to the placenta for gas exchange, they turn into medial umbilical ligaments. If I were to cut open your abdominal muscles and open your abdominal cavity and show you the underside of your abdominal muscles, you would see 2 white lines going like this up to your belly button. And those are your medial umbilical ligaments, remnants of your umbilical arteries. When you were a fetus, you had 1 umbilical vein carrying oxygen-rich blood from the placenta back into your belly. And that umbilical vein turned into a structure called the round ligament of the liver, which you will see again in our digestive system. You're going to see the ligamentum teres, which means round ligament of the liver. So here is that flow chart of all those fetal structures and what they are shunting the blood around. Again, most of the blood entering the right atrium does not go into the right ventricle in the fetus. It goes through the hole in between the atrial wall called the foramen ovale. It turns into the fossa ovalis. Blood that gets into the right ventricle on its way to the pulmonary circuit, it gets ejected into the pulmonary trunk, and instead of going into the pulmonary circuit, it travels through a connecting vessel between the pulmonary trunk and the aorta called the Ductus Arteriosus. That turns into the Ligamentum arteriosum. At birth, chemical changes make these structures start to collapse and be replaced by connective tissue. So your ductus venosus collapses and turns into the ligamentum venosum. What chemicals? Lots of them. First, more oxygen, because now the baby is breathing on its own. Number two, once the baby is born, chemicals present during pregnancy and labor and delivery, they are no longer present because it's the mom that made them. So once the baby's born, those chemicals can't get into the baby's blood supply anymore from mom. So these chemicals are pregnancy hormones and other chemicals known as prostaglandins. So as the levels of those chemicals change, that's what makes these structures start to also change. The ductus arteriosus collapses and turns into the ligamentum arteriosum. The hole in the atrium, the hole actually has a flap. So once the baby starts breathing on their own, the pressure on the left atrium is higher than on the right. So the pressure closes that door and then it seals shut. And that's called the fossa ovalis now. Are there any questions about this change from fetal structures to, quote, adult structures? Okay, well, are there times when this change doesn't happen? Can someone's foramen ovale not close off, and you're seeing it closed off over here? So I'm coloring in light blue the fossa ovalis, and over here you can see the foramen ovale being the hole through the interatrial septum.
It happened to my mom.
Yeah?
Yep, she had a stroke because a blood clot went through and then up to her brain. They had to go and fix it with like a mesh thing. That was interesting.
Yes. So most people, if they have a patent foramen ovale, it largely goes undetected, because even if the hole is still there, the flap of tissue is usually held shut from the pressure on the left side being stronger than on the right side.
Yeah, she was in her 60s when all of this happened, so it was a long time, obviously.
So like I said, if it's there, usually it doesn't cause any problems and it goes largely undetected. A lot of times, when do we detect it? Usually when the person is being physically exerted. Well, who would be forced to physically exert themselves? New military enlistees. So one of my son's very good friends from high school went to the Coast Guard Academy. And of course they do their training, their boot camp, that sort of thing. And on the East Coast, hot, humid weather, doing a lot of training drills, he collapsed. They sent him to the infirmary thinking it was heat exhaustion, dehydration, but they have to do tests. And sure enough, they found this hole, this defect in his interatrial septum, and they were going to dismiss him from school. And he had a full scholarship, and they were like, you can't hold up your end of the bargain physically. We're going to send it in front of a board. I forget what they called it, some sort of review, and be ready to go home on the next plane out. He was just ruined with this. And his mom is a nurse locally. She's actually at one of the teaching hospitals. So of course, when she got news of this, she got every doctor in her teaching hospital to start writing letters of how common this is, and physiologically it should not cause too much of a problem for him on a daily level. Come on, be realistic. Even I got involved in the mix, writing anatomically how common this is. And before they dismiss him from school, they should check everybody then, because it's just a matter of time that it might rear its ugly head. Anyway, they ended up not kicking him out. He's still there, and he's graduating in just a couple months. So yay. Happy ending. So that it does happen. And as Jessica said, it can be problematic. Most of the time it is not. Why can it be problematic? Why did it lead to a clot in Jessica's mom's case? Well, if it was a small little hole and the blood wasn't really spewing through it too quickly, physical contact of the blood with the chambers of the heart, or the tissue of the heart, can activate platelets. And when they activate, it starts the clotting process. Anytime blood is allowed too much time to touch the walls of your blood vessel or walls of the chambers of the heart without flowing through and moving, platelets can get activated and you get a clot. And if that clot moves, it's called an embolus, and it can get relodged in other blood vessels and obstruct blood flow, which is what happened to Jessica's mom. So here is a picture of a real fetal heart. Here is the pulmonary trunk right there. It's got the P, so here's PT, okay? And coming up over here, here's the ascending aorta and aortic arch. And you can see this blood vessel, oops, I tried to change my color, this blood vessel here connecting the two. That connector right there is your ductus arteriosus. And over here on the heart model, you're seeing the pulmonary trunk, you're seeing the aorta, and you're seeing the ligamentum arteriosum, the remnant left of the ductus arteriosus. Now, can that stay open in a newborn child? Yes, and then it's called patent. Patent means open. Patent ductus arteriosus, or PDA. No, that does not stand for public display of affection. So patent ductus arteriosus is an issue in the newborn because now the blood will flow. Instead of the blood flowing from the pulmonary trunk into the aorta, the blood pressure is now higher in the aorta in the newborn. Systemic blood pressure is higher than blood pressure in the pulmonary circuit, and blood flows from high pressure to low, just like water flows from high pressure to low. So in the newborn, when the newborn's systemic pressure goes up, the blood will now flow from the aorta to the pulmonary trunk, which means oxygen-rich blood in the aorta is going right back to the pulmonary circuit. You can't, once your blood is 100% oxygenated, you can't oxygenate it more. You can't go up to 150, not under normal physiologic conditions. So having blood flow from the aorta back to the pulmonary circuit instead of going forward into the systemic circuit to deliver oxygen to the tissues of this fetus, or sorry, this newborn. Some of the newborn's tissues are not, and organs aren't getting as much blood delivered to them. So that's an issue, and the baby will look a little blue. The baby will look blue on the left side, okay? On the left side. So their left face, the left part. So I'm doing this so that for you it's your left. I guess depending on how you have your camera set up. Anyway, the left side of the baby's face and left shoulder will be a little bit blue. It almost looks like they'll have a bruise. So this is a classic type of cyanosis where it's just the left side of the face and left upper member that look blue. And what do we do for patent ductus arteriosus? All we do is very non-dramatic. We give the baby more oxygen. Just maybe put them in an oxygen tent, and we change that oxygen level just a little bit for a little while, and then the ductus arteriosus should collapse and close off. Usually we don't need surgery for it. But if that doesn't work, all we have to do is go in, and we don't even have to cut open the baby's chest. We can do this with very small instruments, go through the chest wall, and we just put a little suture or a little clamp around that ductus arteriosus. We pinch it shut, call it a day, baby's fine. Of all the things that can be wrong with a newborn infant, this, I gotta tell you, is an easy one to get through. Easy peasy. Are there any questions before I stop this recording and we have a break?